Today we'll be talking about intestinal cancer. When we talk about intestinal cancer, we are talking mostly about large bowel cancer, large intestine cancer, because out of the 100 cases of intestinal cancer, 95% of them are large bowel cancer. The symptoms of intestinal cancer depend on the location of the cancer. So you have in the large intestine, you have the rectum, which is in the left lower part of the abdomen through which the stool comes out. Then you have the descending colon on the left side and ascending colon on the right side of the colon. And then you have the small intestine, you have 6 meters of small intestine, which is jejunum and ileum, which are the two parts of small intestine. So cancers in the rectum, they usually present with fresh bleeding in the rectum. Fresh bleeding when you're passing stools, associated with the increased frequency of stools, wanting to go to the toilet very frequently, and something which we call tenesmus. It is a uncomfortable urge to pass stools and a feeling of incomplete evacuation. Once you pass stools also, you feel like you have not fully passed. So patients with these kind of symptoms should get themselves checked for rectal cancer. The left-sided colon cancer presents with symptoms of mainly obstruction. That means the tumor in the intestinal lumen obstruct the flow of stools and gas. So that leads to abdominal bloating, abdominal distension, sometimes intestinal obstruction. That means the patient has emergency symptoms of a tight abdomen with persistent vomiting and abdominal pain. So those are the kind of symptoms of left-sided cancer. While right-sided cancer and transverse colon cancer can sometimes present with obstruction, but most of the time they present with slow onset bleeding. So the bleeding, when it's like in the rectal cancer, it's visible bleeding. When you pass stools, you have blood in your stools. But for the right-sided colon cancer and the transverse colon cancer, you don't get any visible bleeding. Patient only presents to a doctor with anemia, that is the hemoglobin has come down and it gets checked. So this is one of the areas where a lot of negligence occurs. A lot of patients who have anemia for 6 months, 1 year, they don't get themselves checked, and then the colon cancer in the meanwhile it grows very large and becomes advanced colon cancer. So especially people who are like above 45, 50 and men and women who are beyond the menstrual, post-menopausal women, if your hemoglobin comes down, it has to be immediately evaluated to rule out colon cancer. Other than that, of course, in advanced colon cancer, you can have symptoms like weight loss, decreased appetite, abdominal distension, jaundice, but all these are features of very advanced colon cancer. Likewise, small intestine cancer, though it's relatively less common than large intestine cancer, this can present with features of intestinal obstruction. We call it subacute intestinal obstruction. That means patient after food, he can have crampy pain in the abdomen, which comes and goes in waves, which is associated with intermittent loose stools, intermittent constipation. Patient can have vomiting, and small bowel tumors can also present with anemia. So there's a slow degree of blood loss which is not available, visible in the stools. So when you pass stools, you don't actually see blood in it. We call it occult GI bleeding. That means not visible to the naked eye. But because of that, because daily you lose some blood and then you become anemic. Your hemoglobin goes down. So again, I reiterate, in patients with anemia, persistent anemia, if your hemoglobin is persistently less than 9 and it's continuously, rather than just taking tablets for it, you need to get yourself evaluated to rule out intestinal cancer. The risk for intestinal cancer is in terms of lifestyle. Patients who are obese, patients who eat a lot of fatty food, patients who eat a lot of preserved and canned foods, patients who are smoking, chronic smokers, chronic alcoholics. So these group of patients are at risk of colon cancer. But in addition to these regular lifestyle risks like obesity, smoking and alcohol, colon cancer is very strongly positive in patients with a family history. So if your father or mother or any of your first degree relatives, your uncle, blood relatives, blood first degree relatives have had colon cancer, you're at a much higher risk, because colon cancers occur due to mutations in your large intestine, which are transmitted from family member to family member, and patients who have a risk of family history of colon cancer are at risk of developing colon cancer. So this risk is not just in patients with a family history of colon cancer. There is hereditary non-polyposis colon cancer. This is like a Lynch syndrome, we call it, in which patients with not just colon cancer but family history of other intestinal cancer, family history of stomach cancer, family history of endometrial cancer, family history of ovarian cancer. So if any of your family members have these group of cancers like ovarian, endometrial, stomach, large bowel, small bowel cancer, then you are at a risk of colon cancer. So all these patients starting from 50 years of age, you should have every 5 years you should have a colonoscopy checkup done to rule out colon cancer. So in addition, there are some other groups of patients who have some diseases like ulcerative colitis and Crohn's disease and polyposis coli. They are specialized conditions. Patients usually go to a doctor with bleeding in stools and increased stool frequency. When the doctors diagnose conditions like polyposis coli and ulcerative colitis, these patients are at a risk of colon cancer. So they need to be get checked at regular intervals with a colonoscopy to diagnose colon cancer. The diagnosis of colon cancer is pretty straightforward. It requires something called a colonoscopy. Colonoscopy is a camera passed through your from the bottom into the large intestine. We look at the entire large intestine, see any areas of suspicion. In patients with early colon cancer, patients who are just being screened for colon cancer, if you have suspicion, we can do something called NBI, narrowband imaging. It is a special type of light which we use in the colonoscope to detect early colon cancer. So with colonoscopy, almost 99% of the colon cancers can be effectively diagnosed at a very early stage in patients who have symptoms. And patients in whom, with your family history of colon cancer, you have symptoms of colon cancer, if you have anemia, hemoglobin going down due to colon cancer, it's mandatory that you go to a gastroenterologist and get a colonoscopy done. Once you have a colon cancer, which is proven by biopsy on the colonoscopy, we do other tests like CEA, which is a carcinoembryonic antigen, which is a screening blood test for colon cancer. We can do a CT scan and a PET CT scan to stage the colon cancer. Is it limited to your intestine? Has it spread elsewhere to the lymph nodes outside the colon? Or has it spread to the liver or the lungs, and so on and so forth? So the question is whether screening is needed for asymptomatic individuals, that is patients without any symptoms. Do you need to screen for colon cancer? So in the Western countries, every citizen in the Western country, irrespective of be it Asian, African, Caucasian, is screened for colon cancer starting from 50 years of age, every 5 years for the rest of his life. Why? Because for two reasons. One, the incidence of colon cancer is very high in the West, and the other reason is that these colon cancer forms from colonic polyps. So you have polyps, which are small outgrowths which form in your large intestine because of some mutations in the intestinal cells. Once these mutations occur, by a series of subsequent mutations, a polyp will develop into a colon cancer. This process of a polyp becoming a colon cancer takes approximately 5 to 15 years in various individuals. So if we do a screening colonoscopy and identify a polyp and remove the polyp, treat the polyp, we can actually prevent colon cancer. Most patients with colon cancer, majority of them, in them the colonic cancer forms from a polyp. So they've had a lesion in the intestine before, at least 5 to 10 years before they develop the cancer. So in a person who has a colon cancer, he has had a lesion around 5 to 10 years before itself, a polyp which has slowly over these 5 to 10 years progressed into a colon cancer. So if we do a screening and identify the polyp at the right time, removing it can prevent colon cancer. So based on this philosophy, worldwide colon cancer screening is done. Unfortunately, in India, we don't have the exact data as to what is the incidence of colon cancer, and because healthcare is it's not just like in abroad, it's not like under a single umbrella organization. There's so many sources of healthcare, government, private. Clear-cut recommendations are missing regarding the need for screening for colon cancer. But I would recommend that everyone over 50 should have a colonoscopy once in 5 years. In addition to that, like we said, the special groups of patients, if you have a family history of colon cancer, if you have family history of more than one colon cancer, so 2 family members in your family have had a colon cancer or a colon cancer related cancer like an ovarian cancer, endometrial cancer, stomach cancer. So if they have this hereditary non-polyposis group of cancers, you should in fact start your screening at a much younger age. So if a patient has family history of colon cancer, if your father or uncle, paternal side uncle has had a colon cancer at 40 years of age, it is better to start the screening at the age at which they develop the cancer. If it's in a younger patients who develop cancer at a younger stage are more likely to have hereditary colon cancer. So if your family member has had at 40 itself, don't wait till 50. You start the screening a bit earlier when your other family member had colon cancer. Likewise, patients with the special risk groups which we discussed before, patients who had radiation to their intestine before, patients who have past history of colon cancer, patients who have ulcerative colitis, patients who have Crohn's disease, all these patients need to undergo regular screening for colon cancer as per the gastroenterologist advice. Okay. Colon cancer. Treatment of a colon cancer is an area in which a huge amount of scientific advancements have been achieved in the past 3 decades, and it is one of the areas of cancer where absolute evidence-based medicines, that means a treatment, the medicine or the surgery, whatever we do is backed by a huge amount of scientific data, high quality scientific data. We have that in colon cancer. So the treatment of colon cancer should be a multimodality treatment. So it is not a surgeon or a oncologist or a radiotherapist who decides. It is a combination. The surgeon, the oncologist, the radiotherapist, the gastroenterologist, all of them get together and the multimodality treatment is formed. So patient first gets staged by a colonoscopy, a diagnosis formed, then he gets a staging done by special tests like a CT scan, an MRI, an endorectal ultrasound, and these kind of tests. Then the multimodality team discusses it, and many times, like for example, in a rectal cancer, first we give radiotherapy, downstage the tumor, downstage meaning we shrink the tumor and then go for surgery. And after the surgery, sometimes we may give chemotherapy. For ascending colon cancer, we generally do surgery first, and once surgery is done, in the post-operative period, we look at the biopsy and we give chemotherapy. So usually for stage 1 and stage 2 cancers, surgery alone is good enough the treatment. While for stage 3 and stage 4 colon cancers, you need both surgery as well as another form of treatment like radiation or chemotherapy. In addition, in surgery, there's a lot of advances made in surgery. Now we do laparoscopic surgery for colon cancer by minimally invasive and robotic approach. Through small incisions, the cancer is removed and the intestine is rejoined. So the postoperative recovery is very quick, and within 5 to 7 days the patient is back on his feet onto his normal life. He can get back to his work within 10 days after surgery, and the patient, even if he requires chemotherapy, the patient becomes very fit very early. He regains his fitness for chemotherapy. So a lot of patients who are undergoing treatment for colon cancer are neglect or become scared about the treatment because of the fear of ostomy. Ostomy is basically when an intestine is put on your abdominal wall and the feces does not come out of your anus, but actually it comes out of the abdominal wall into a bag. So a lot of people fear that if you have colon cancer, the surgeon will put you on a bag, and because of that they delay treatment or defer treatment and then finally end up with very advanced stage disease. So an ostomy in a colon cancer is done in very few selective situations. So most of the time in a temporary ostomy means we bring the intestine out temporarily for a couple of 4 to 6 weeks, and then it's closed and your stool passes through the normal route once again. So we do a temporary ileostomy or a temporary colostomy sometimes for rectal cancer or sometimes for left-sided cancer, in which the patient has come with an emergency situation or like an obstruction in which the colon is hugely swollen up and it's not very healthy to take the stitches. In those kind of patients, we actually do a temporary stoma, and after 4 to 6 weeks the patient gets his normal intestinal route. Well, in some cases in rectal cancer, in the lowermost part of the rectum, when the rectum joins your anal opening, at that point, if the cancer goes till there, you can have the muscles which control the evacuation of stools, the defecation. We call them the sphincter muscles. You have the external sphincter and the internal sphincter. These muscles can actually get involved by the tumor, and in those kind of cases, we can need something called a permanent colostomy. That means the anal opening and the sphincter complex is completely removed to clear the tumor, and then you have a permanent bag. So this is a very small group of patients of the lowermost rectal cancer, that is the carcinoma of the large intestine, which is involving the rectum, which is the area above the anus, and in that the lowermost part. Even that area now, with advanced technologies, we have transanal microsurgery, and a lot of sphincter saving surgeries are being done, for which even patients with the cancer which is coming very close to the anus, we are able to preserve the sphincter. But of course, there are a certain group of patients in whom we have to actually sacrifice the sphincter and go for a permanent colostomy. It is only in these patients that you need a permanent colostomy, but rest of the other groups of patients, like other regular rectal cancer, left-sided cancer and right-sided cancer, most of the time you don't need a colostomy to treat a large intestine cancer. Even if you need it, it is a very temporary requirement. Cancer. So, generally the patients, once you have abdominal cancer, it is a very scary word, and the patients generally have a very dire sort of attitude towards it, thinking that the abdominal cancers have very poor prognosis and the life is very short. It is partly true for some cancers like pancreatic cancer, stomach cancer, gallbladder cancer are some of the abdominal cancers in which despite diagnosing at the right time and giving very good quality treatment, multimodality treatment of surgery, chemotherapy, radiotherapy, despite all these things, the survival is not good. But colon cancer is not like that. In fact, I will say, so in cancer, the success rate is measured by 5-year survival. So when we do a surgery for a group of patients, how many of those patients are surviving at 5 years? So for something like a stomach cancer, it could be 30%. Something like a pancreatic cancer, it could be 40 to 50%. That means you do a surgery for 100 patients, 50 of them are alive at 5 years. So if you're alive at 5 years, that means you're mostly cured of the cancer. It's never going to come back. Likewise, for colon cancer, the 5-year survival is up to 90%, especially stage 1, 2, 3 colon cancers. We have around 90 to 95% is the 5-year survival rate. So the long-term success, the cure rates of colon cancer are excellent. Why? One is the surgeries become very evolved for colon cancer, very safe, with very high success rates, and then the chemotherapy for colon cancer is also evolved a lot. So chemotherapy for colon cancer is very, very effective in preventing recurrence of the cancer. And in addition, you have drugs like oxaliplatin, 5-FU, irinotecan, which are very effective drugs to prevent colon cancer. And in patients in whom these drugs don't work, and in case they have some residual cancer or the cancer come back, we have excellent treatment called targeted therapies. Targeted therapies means, see, your regular chemotherapy has a very broad spectrum of action. It kills all cells. So you have hair loss, intestinal mucosa is affected, leading to ulcers and diarrhea and all those problems. While targeted therapies, so you have drugs like bevacizumab, cetuximab, and these kind of targeted therapies which specifically target growth factors within the tumor to control them. So for colon cancer, you have these kind of specific targeted therapies, which we do some genetic testing on the tumor. Once we take out the tumor, we do MSI testing, microsatellite instability testing, and KRAS mutation testing on these tumors, and then we decide which patients are candidates for this targeted therapy. And in those patients, these targeted therapy have led to vast improvement in the long-term cure of colon cancer patients. So unlike in other cancers, like for example pancreatic cancer, stomach cancer, uterine cancer, once you have stage 4 colon cancer, stage 4 cancer means the cancer has spread from the original organ, like in the pancreas or the colon, it has spread beyond it to involve the liver, the lungs, the brain or the bones. So when that is called stage 4 cancer, advanced cancer. So when you have advanced cancer, traditionally the patient's survival is very poor. In stomach cancer, pancreatic cancer, endometrial cancer, a person who is having stage 4 cancer will usually survive for only a few months. While for colon cancer, up to 40 to 50% of these patients with even advanced cancer can be salvaged by very good multimodality therapy. So patients with advanced cancer which is spread beyond the colon into the lung, liver, so we can salvage them by, we do surgeries for liver metastasis. For lung cancer, we remove the part of the tumor in which, part of the lung in which the tumor is there. We do something called radiofrequency ablation to the tumor. That means a wire which provides thermal energy is inserted into the tumor to destroy the tumor. We use second line, third line chemotherapy, targeted therapies like cetuximab, bevacizumab and all those drugs. By all these modalities, we can actually cure, not just prolong the life, we can actually cure patients with advanced colon cancer. In fact, patients with very disseminated, we have patients with colon cancer which is spread throughout the abdomen, inside the peritoneum, causing multiple thousands and thousands of tiny cancer deposits. In these patients also, we've done something called HIPEC, hypothermic intraperitoneal chemotherapy, because with using that chemotherapy and a surgery called Sugar-Bakar surgery, we can actually have long-term cures for even this group of patients. And of course, there are a group of patients in whom all these treatments can also fail. In these patients, we can relieve the symptoms. So in patients in which the colon tumor is bleeding or it's causing obstruction, surgery can relieve the symptoms. Those obstructed and bleeding symptoms can be relieved by surgery, by the surgical gastroenterologist, the oncologist, oncosurgeon, or a gastroenterologist can put in a stent, metallic stent into the intestine and give good symptom relief for these advanced cancer patients.